Thanks very much, everyone, for joining us on this very, very hot summer evening. I think we'll get started now because it's already a minute past. So we're absolutely delighted to have Professor Craig Shimasaki with us again. As you know, he's the CEO of Molecular Biosciences, where AONM is very honored to be providing their excellent test of autoimmune antibodies in the brain here in the UK. If you have any questions or comments, please do put them into either the chat or the questions, the Q&A, and we'll have ample time at the end to answer them. Professor Shimasaki will speak for about 45 minutes. I'll just introduce him briefly. He received his BS in biochemistry from the University of California and his PhD in molecular biology and biotechnology from the University of Tulsa. He's an adjunct professor at the University of Oklahoma and the co-founder and CEO of Molecular Biosciences, which is a neuroimmunology precision medicine company focused on identifying and treating the underlying roots of neurological, psychiatric, and behavioral disorders triggered by an autoimmune response. He's spent over 35 years working in this and related fields, and so has just so much experience to offer us. I'll leave Professor Shimasaki to introduce anything else from his background that he'd like to say, but let's spend all the time we can with you, Professor Shimasaki. So thank you very, very much. Over to you.
Thank you, Jillian. It's a pleasure to be able to speak with you this evening. If you're out there in the UK or wherever you are, the United States, it's in the early afternoon. But it was a delight to be in London a couple of weeks ago and speak at the Integrative Mental Health Conference and the Integrative and Personalized Medicine Conference there. It certainly is amazing to hear and see how much is going on as far as answers to chronic disorders and finding solutions for patients, of which grateful to all of you who are out there at the front line practicing and taking care of these patients. So what I hope to do today is to share with you some background, talk to you about the connection between infections, the immune system, and the brain, and bring a little more understanding as to what we do know and understand at least about how inflammation, the immune system, and the brain are intertwined in a way that often these different types of disorders get misdiagnosed because of symptoms, but underlying it, we find that there is an immune-mediated root. So let's get started, and we'll have some questions and time for questions at the end of the session. So we're going to cover three things today. One, talking about the connection between infections, the immune system, inflammation, and various types of neuropsychiatric disorders. And then I want to introduce, if you haven't heard the topic, molecular mimicry, because it's really something that I believe is the root of the majority of a lot of autoimmune conditions and many other chronic conditions that result from an immune-mediated disorder. You probably have heard of PANDAS and PANS, but also things such as neurologic Lyme, of course, long COVID, and many other types of disorders that result from an infection-triggered immune-mediated condition, which we'll talk about. And then we're going to talk about some case studies. So we're going to look at the presence of these autoimmune antibodies against 5 different targets in the brain and see how they are correlative with different types of conditions. And then what are some of the things you can do to actually identify them and then use them and as a means of directing treatment and then getting your patients well. So let's start by talking about inflammation. So we do know that inflammation and immune dysfunction are more and more understood to be some of the roots of many, many chronic disorders. And you can see here from diabetes, cancer, obviously arthritis, and even Alzheimer's now is believed to be an immune-mediated event which triggered many many years, in fact, potentially decades ahead as these tau and amyloid plaques begin to build up. And we're going to talk about neuropsychiatric disorders today. But all inflammation is not bad because inflammation plays a very important role in warding off infections, healing our body, alerting our immune system to begin a healing process. And that's the acute inflammation. But there's a difference between acute inflammation and chronic inflammation. And this is inflammatory events and the immune system being activated for long periods of time that can lead to autoimmune diseases. Even we'll briefly talk about cancer, cardiovascular disorders, Alzheimer's, and what we're going to focus on today is psychiatric and behavioral disorders. So let's look at an interesting case as one of the examples. This was identified, at least publicly, in the New York Times. This is an individual who was diagnosed with paranoid schizophrenia in Japan, and the doctor was a psychiatrist at the Shumei University School of Medicine in Japan. And he was prescribing his patient a whole series of antipsychotic drugs for his symptoms, and nothing improved his condition. In fact, most likely, much of this actually worsened. So he deemed him to be treatment resistant. And then a year later, the patient developed myeloid leukemia, and then he needed a bone marrow transplant. Well, what happened was, interestingly, after the bone marrow transplant, his schizophrenia, they said, seemingly vanished. So the comment from the doctor was he's completely off all medications for schizophrenia, shows no psychiatric symptoms, says somehow the transplant cured this man's schizophrenia. So the actual medical case was published in Frontiers in Psychiatry. And what you can see here in this image here is his positive and negative syndrome score was very high until he had his bone marrow transplant, which dropped down to almost baseline. And this global assessment of functioning score was really, really low and rose up to basically what they said: he's returned to normal. He's off of olanzapine and all the other drugs that he was on for psychiatric meds. So what happened to this patient? Well, this is what we're going to talk about in brief about the immune system connection to many parts, including the immune surveillance component. So I want to share an axiom that I believe is going to become more and more relevant and understood. And I believe that people will find that autoimmune disorders, meaning immune-mediated disorders, and cancer have a very close biological relationship. They are basically two sides of the same coin. Why do I believe that? It's because this regulation of the immune system's self-non-self tolerance is at the root of both of these conditions. So in autoimmune diseases, this is where the immune system recognizes self as being foreign and attacks itself. Whereas in cancer, the immune system recognizes foreign as self, meaning the cancer cells are not being recognized as being foreign, but they think they're self. And so we do see when some of these autoantibodies, not the ones we're particularly talking about today, but many of these others, which are called paraneoplastic antibodies, meaning they're often associated, there's an underlying cancer that's co-occurring with these neuropsychiatric symptoms. So this results in a dysfunction of either the innate or the adaptive immune response, or both. And what we frequently see is then responses to immunomodulatory therapy impact both, as in the case that was described previously, where the bone marrow transplant, quote unquote, cured the patient's schizophrenia, but also alleviated him of his leukemia. So let's move on to say, why is this challenging to diagnose patients with these complex disorders? Well, one of the reasons is that because in medicine, typically, at least in the United States and probably elsewhere, is the prevailing model of disease biology is segmented. meaning that immunology, psychiatry, psychology, neurology, oncology are all separated into different subspecialties. Whereas in actuality, we know that biology does not segregate these, in fact, inside our own body, whereas they are impacting each other: psychiatry, psychology, neurology, infectious disease, immunology, and is what we saw, oncology or cancer. So cross-disciplinary and collaborative medical care is really important to accelerate the diagnosis and treatment of these chronic disorders. Now let's talk about psychiatric conditions. So worldwide, there's over 800 million individuals who suffer from different types of neurologic, psychiatric, and behavioral disorders. These names of these disorders can be seen here. You're familiar with many of them. The interesting thing about each of these is these disorders are diagnosed by clinical symptoms, not by biology. And so the description is based upon constellations of symptoms and, of course, ruling out other things. So, for instance, if a patient has motor or vocal tics for more than 12 months, by definition, that's the underlying diagnosis of Tourette syndrome. So patients are typically being treated for symptoms rather than addressing the underlying root cause. And this is where it breaks down for patients with these chronic immune-mediated disorders that result in these neuropsychiatric conditions. And as was mentioned in the previous study or previous report, 20 to 60% of these patients are deemed treatment resistant. And that's because their underlying etiology of the disorder is not necessarily what you would think of as a typical psychiatric syndrome. So the question now becomes, can infections trigger an autoimmune response that could lead to these different types of neuropsychiatric disorders? In 2019, JAMA Psychiatry, which is a reputable journal, published a Danish study of over 1 million patients who were followed from birth to age 18 years old. And they looked at these medical records and they looked for correlation. And what they found was that if an individual was hospitalized for a severe infection, that the risk of developing mental disorders increased by more than 80% for the diagnosis of schizophrenia, autism, OCD, ADHD, personality disorders, oppositional defiant disorders, tic disorders, and many more. So the editors made a statement: how could exposures to infections affect the brain mechanistically to give rise to mental disorders? Their answer was circulating autoantibodies that enter the brain via a compromised blood-brain barrier, bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in PANDAS and other mental disorders. So if you're familiar with PANDAS, we'll briefly talk about that. But PANDAS is a medical model, we believe, for many of these other chronic disorders, just as you saw with the patient diagnosed with schizophrenia. Now, they're different conditions, they result in different symptoms, but remembering that these diagnostic names are constellations of clinical symptoms, and that a large portion of neuropsychiatric disorders are caused by infection-triggered autoimmune dysfunction. So if we look at this biologically so we can understand it, how does this occur? Because we all get infections. Everyone is exposed to viruses, bacteria, microbes, fungus, etc. And we all make antibodies ultimately that recognize these infectious agents through our adaptive immune system. Whereas in certain individuals, and we'll talk about this briefly, the antibodies that they make end up cross-reacting with certain neurologic receptors, and we'll talk about molecular mimicry and why that's the case. And then that results in the disruption as it transverses through the blood-brain barrier in the actual fidelity of the inner neurons and the pre and postsynaptic communication in these nerves, and we call this friendly fire, meaning you can't tell the difference from what's the good guys and the bad guys. This results in the neuropsychiatric symptoms, many of them that we'll talk about that have been described. And then what happens is they're placed on these various types of symptomatic treatments for neuropsychiatric disorders. Now, for patients, a large number of patients who are not immune mediated, clearly these have been very helpful. But in patients that are immune mediated, this is not one of the treatments that actually result in effective resolution. What we find is that immune modulators, anti-infectives, and anti-inflammatory agents result in some remarkable recoveries. So autoimmune neuropsychiatric disorders that are triggered by infections are not new. We can go back into history and we can see that this, what was called St. Vitus's dance, which is now known as Sydenham chorea, were abnormal movements, loss of fine motor control, and emotional control that occurred in children, occurred way back in the 1600s, and or at least recognized it even occurred before that. And then in the 1600s, Thomas Sydenham described this as he called it chorea minor and chorea because of these movements, or these uncontrolled, sometimes looking graceful movements. And then in the 1800s, Sir William Osler described these, what he called bizarre and percipitive behaviors in children with chorea minor, including obsessive compulsive disorders, symptoms, chorea minor, etc. We do know that this is a result of group A streptococcal infection that results in attacking the brain and certain parts of the brain, which we'll talk about. But it also is a results in rheumatic fever, and rheumatic fever is where these antibodies are attacking the heart. 30% approximately of patients with rheumatic fever end up exhibiting Sydenham chorea. And it's just the unlucky draw of where these antibodies are directed. So as I mentioned, brain-reactive autoantibodies have been known for a long time. In fact, you can see the growing list of many of these. And in fact, the one at work that we have done, and through my co-founder, Dr. Cunningham, maybe about 20 years of research have gone into identifying the 5 ones we're going to talk about. GAD65 is also one, if you're familiar with Celine Dion's disorder called stiff person syndrome, where she couldn't sing and had trouble with fatigue and a whole host of different types of incapacitating syndromes. These antibodies are directed against this particular target. The NMDAR receptor is also one. If you've seen or heard of Susanna Cunningham, she wrote a book called Brain on Fire, in which she was totally normal, and then suddenly she developed psychosis, paranoia, hallucinations, and a whole host of symptoms until someone was properly diagnosing it and found the autoantibodies directed against the NMDAR receptor. Also, if you didn't read the book, you can see the movie. Hollywood produced a movie on that. So let's talk about PANS and PANDAS. If you've heard of PANS and PANDAS or have seen patients with PANS or PANDAS, there is a strict definition of what is PANS and PANDAS, but we believe that they are medical models for other immune-mediated neuropsychiatric disorders. And we're grateful to Dr. Susan Sweeto, who is the pioneer who actually and her team studied and identified these children who had a sudden onset of obsessive compulsive disorder that resulted from a previous onset of strep infection. My collaborator and her worked on identifying the antibodies in these patients, and this is what we're going to talk about a little bit more. This was published back in the late 80s, and you see that this was the first 50 cases that were described. So let me back up a little bit because nomenclature can be a little bit challenging, but PANDAS refers to pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. Therefore, if you don't have strep or you're not a child, you can't have PANDAS, even if you have the same type of symptoms by other microbes or environmental factors. So it could be infectious or non-infectious. So this is where the term PANS came about. PANDAS eliminated the term streptococcal infection and described it as a syndrome-wide that could be infectious or non-infectious. However, guess what? If you're not a child, you can't have PANS or PANDAS, but you can still have those same symptoms. So there have been other terms coined like ANDL, adult or autoimmune neuropsychiatric disorder associated with Lyme. And there are many more, which I won't go into. But basically, all of these are referring to what we like to think of an autoimmune encephalopathy, meaning a disorder of the brain, secondary to an infection. Sometimes it's referred to as an autoimmune encephalitis, although the connotation is a direct infection of by the organism or the infectious agent, which is not what's happening. Or sometimes even you'll see basal ganglia encephalitis because the part of the brain that is impacted in here is the basal ganglia, and we'll talk about that in just a second. But really, we're looking at an immune dysfunction that's resulting in neuropsychiatric and behavioral disorders that are triggered by an infection, irrespective of the age of the patient, the type of infection, and the cause of the infection or the non-infectious agent. So back to the basal ganglia, there's been published studies showing in children that have OCD and tics and streptococcal infections that you can see increase in inflammation or increase in the caudate, the putamen, the globus pallidus due to the inflammation, whereas not the thalamus, which is not part of the basal ganglia. So what does that mean? Well, the basal ganglia is responsible for motor control, procedural learning, cognitive functions, emotional functions, eye movement, and many other things. And so before I leave here, let me share Sydenham, chorea. Remember, involuntary motor control, cognitive functions, emotional functions being affected. And I won't go into the studies, but there's been published studies showing that these antibodies are directly binding to tissues in the basal ganglia. On our side, we've been following also the financial impact and burden of care of families with these autoimmune neuropsychiatric disorders. And you can see some of the comments that have been written into many of these patients that have taken the quiz and have helped us as we collect data to look at the impact and the burden of care, as you probably know. And what we do see is that these patients' typical journey is really they struggle for many, many years, seeing between 5 to 15 medical providers and spending in US dollars, sometimes between 20 to 100,000 or more, until they find an answer. And so we've now tested over 16,000 patients since we've been open, literally from throughout the US, but over 50 different countries, who have found out about what we do and that they have reached out and have found help, and then now through AONM, who is our partner in Europe. So it is a challenge for clinicians and patients who actually suffer, for patients suffering from these conditions. And the important thing is to recognize that there is a biological component, and it does make sense. So now we're going to move to molecular mimicry here. And why do these infections trigger these neuropsychiatric disorders? And how does that happen? So let me just back up with a little bit of immunology and just explain here that if you remember your immunology courses, our immune system is already pre-programmed to recognize any antigen that it will ever come in contact with. So that's 5 times 10 to the 13th unique antigens. Well, how does it do that? How does it do that? Well, it's because basically these genes are being rearranged in random fashion so that it creates this antibody diversity. Remember, the VD and J segments are joining together, so it looks like just a bunch of genes through rejoining and doing this, and they create then these particular recognition portions of these antibodies. What that means, though, is that we have already self-reactive lymphocytes that are generated in the process, because there's going to be a lot that recognize ourselves. So how does our body stop that? How do they eliminate it, and how does it understand self, non-self? Well, there's two processes that we know about, and that is called central tolerance, where in the bone marrow and in the thymus, there becomes a training process. So each of these lymphocytes will go through and be recognized. If they bind to self-presenting antigen, they're killed through various things like apoptosis and other types of ways in which they'll destroy these cells. Now, if occasionally they get out, there's a backup plan, and that's called peripheral tolerance. And that is where in the spleen and the lymph, these cells that have escaped the bone marrow and the thymus, they actually go through the same process again, and they will pick up any of these self-recognizing lymphocytes, and they'll destroy them by anergy or deletion or apoptosis. So you've got a primary system and a backup system. Well, what happens if maybe you've got some genetic mutations in some of these systems that don't correctly function? Autoimmunity is the breakdown of self, non-self discrimination, and we think of this as friendly fire. And this is why the most relevant genetic factors we see in this are the major histocompatibility complex, or the MHC, and the HLA class 1 and class 2, which has to do with self, non-self recognition. Therefore, practically what you typically will see is that there's a family history most of the time of some type of autoimmune dysfunction in patients with these immune-mediated neuropsychiatric disorders. Now, not all the time, but a very high majority of the time. So if you take a good family history and a good history in physical, you'll find that this is often the case. So what is molecular mimicry? Real quickly, basically, since there are only 20 letters of the human protein alphabet that we typically use, there are many others, but these are our standard letters of the protein alphabet. And in some sequences, there's going to be a random identical sequence in either a virus, a bacteria, a protein, an organism in which they're identical. Now, the self, non-self, central peripheral tolerance will eliminate those if an antibody is actually proliferated based on that. But what happens here if you have this sequence of proteins and an antibody didn't get eliminated, or this lymphocyte didn't get eliminated? You've got an antibody that's against a sequence that's identical to, let's say, a neuron. Well, once that escapes, that actually then allows this self-reactivity and this autoimmune process. So therefore, you've got this antibody that is recognizing a part of an organism, but it also is recognizing an identical part of our own body. So this occurs with multiple infections because there's some sequence homology between them. Group A strep is one of them, influenza, varicella, mycoplasma, Babesia bartonella, Lyme disease, Coxsackie, and many others. So I won't go into too much of this, but strep, because of PANDAS, is one of the first ones that was really identified. And there's a correlation between the heart valve proteins and the basal ganglia, hence Sydenham, chorea, and rheumatic heart disease. There's also correlation between Borrelia burgdorferi, which is one of the causative agents of Lyme, and the strep M protein, which, as I mentioned, has homology between that and some of the parts of the body. So this is why we may see and do see patients infected with Lyme can and sometimes do present with various long-term chronic neuropsychiatric symptoms. There is also sequence homology between certain dopamine receptors and the SARS-CoV-2 spike protein. So we've done the sequence analysis, we've seen some of these together, and those between the dopamine D2 and the D1 loop, we find that there is sequence homology. So this could be one of the reasons why we also see neuropsychiatric symptoms occurring in patients with long COVID. And long COVID, as we know, is just the effect of a virus triggering the immune system directed against the brain, the heart, the lungs, blood vessels, and other organs. So again, this is not new. There are other infections that are associated with through molecular mimicry for Guillain-Barré syndrome. We already talked about Sydenham chorea, lupus, MS, myasthenia gravis, cardiomyopathy, which is a second panel that we're working on, and myocarditis, and Crohn's disease, diabetes, psoriasis, and the list goes on. It is interesting to note that strep cases surged dramatically after COVID, as you can see, during that period of time when there was quarantine and people were sanitizing and being hygienically very careful. And then there was an explosion of strep infections after the quarantines were lifted. And even in the UK, you saw a surge of scarlet fever that occurred during the 22-23 parts of the season after the lockdowns were lifted. So other immune-mediated disorders, rheumatoid arthritis, we're talking about antibodies against the joints, diabetes, antibodies against parts of the pancreas or parts of the insulin-producing cells, multiple sclerosis against the myelin sheath, and now we're talking PANDAS, PANS, potentially parts of autism, schizophrenia, etc., where antibodies are directed against the basal ganglia or parts of the brain that result in this. So to sum up molecular mimicry, basically it's a misunderstanding or a lack of an ability to distinguish between self and non-self. So let's move into some case studies here. We'll spend some time looking at this. So we're looking at a 17-year-old young man who had multiple neuropsychiatric symptoms. And we identified in this patient that they had a whole host of symptoms, including obsessive compulsive disorders, sensory and motor abnormalities, separation anxiety, sleep disturbances, aggressiveness, and you saw creiform movements. So in the Autoimmune Brain Panel, which we'll talk about a little more, we look to see if any one of 5 antibodies against these targets or a cell stimulatory assay is present in these patients. We found one, and the positive test is that one or more of these antibodies are directed against these targets. This was a CAM kinase positive, indicating that it stimulated this particular enzyme. They had a relapsing remitting. There are many different things that go on you can see in the diagnosis. And of course, they had found they had other infections, Coxsackie, parvo, HHV6, and Marcon's positive, sinusitis. And there was a history of rheumatic fever. And they tried NSAIDs and multiple IVIG infusions for the inflammation and the immune system, and the patient was improved dramatically. And we tested him after the treatment, and that patient's CAM kinase resolved there to near baseline. So another study of a 16-year-old female who also had OCD and motor tics, but she exhibited what looked like restricted food intake, or sometimes could be confused with anorexia. This is not an image issue. It's actually a fear of food contamination or choking or some other phobia that is really an OCD. So she had the abrupt onset at age 11, and she had motor and tic movements and difficulty in her academic studies, sensory abnormalities. This one was pretty severe in that this aggressive behavior, the parents had to call the police 6 times. And unfortunately, in this case, we saw a elevated CAM and 2 borderline anti-tubulin and anti-dopamine D1. So it was also relapsing remitting, previous diagnosis of other infectious encephalitis. Of course, here we saw positive Lyme, elevated mycoplasma, and Coxsackie virus. And the maternal and the paternal grandmother also had autoimmune disorders, and interestingly, although rare, a history of rheumatic fever. So they used plasmapheresis in these cases and IVIG with just an amazing symptom improvement, and put them on low-dose Zoloft and Abilify for maintenance. Patient was remarkably improved, and as you can see, patient's CAM kinase returned to near baseline. There was borderline still the tubulin, but the others were there, and this patient continues to improve. And once the patients are treated and they begin to improve, often they don't need any additional treatment. This case study of an 8-year-old girl with neuropsychiatric symptoms, abrupt onset, and sometimes you can see urinary and sleep problems and poor concentration, etc. And this individual had a lysoganglioside positive and a tubulin positive. And anxiety, OCD. Interestingly, they did not find, they were testing for strep, but any evidence of a strep titer through ASO and DNase-B. But to remember that strep can occur in any orifice of the body, and sometimes you may not be able to see it. So there were significant 2 recent streptococcal infections and other types of sinus infections and idiopathic fevers. The family history was positive for mycoplasma, autoimmune disorders, etc. And this was when the patient was caught early enough and they were treated with a course of azithromycin and rapid improvements to address the infections, and all symptoms resolved and returned to baseline after 2 to 3 days of treatment. And what you can see is the antitubulin and the lysoganglioside both returned to baseline. This is a published study of a patient with schizophrenia at the Children's Hospital in Cincinnati. You can see the paper, read the publication. And this particular individual was a 15-year-old girl who was diagnosed and treated unsuccessfully for schizophrenia, very similar to probably this other patient in the beginning that I shared. However, she was going to be put back in a treatment facility. They called in an immunologist. He knew about these autoantibodies that we test for, found that the dopamine D1, D2, lysoganglioside, tubulin were all elevated, and the CAM kinase was borderline. They said after 1 course of plasmapheresis was administered, the patient had complete resolution of her psychotic, OCD, anxiety. She was weaned off olanzapine and resumed her normal activities, including tennis, within 2 weeks after plasmapheresis. And a response has been sustained for over 6 months, consistent with previous studies. So after reading this, we contacted Dr. Bernstein and asked for a sample of his patient. And we tested that, and we found that all her antibodies had returned to baseline. So let me try to sum this up here in the time remaining here. We'll talk a little bit about how these correlate. So we're talking about the Autoimmune Brain Panel because it's a constellation of 5 targets. But what we find is that some patients who have positive with dopamine D1, they exhibit more psychiatric symptoms and mood swings, depression, anxiety, irritability, delusions. Sometimes they even exhibit psychosis. When we find antibodies against dopamine D2 receptors, we do typically see movement clusters, meaning choreiform movements. Patients who can't really sit still, maybe they end up with ADHD diagnosis, sometimes even Parkinson's diagnosis. So sometimes we will even see that. When patients come with antibodies directed against lysoganglioside, we see patients frequently complaining joint connective tissue pain and various tics. We see a high frequency of antitubulin. And what we were looking at frequently is what we saw is that patients complained of brain fog, often OCD, other food phobias. Tubulin is actually an intracellular protein that's highly concentrated in the brain, and we actually use these isolated from mammalian sources to be able to do the testing. Now, the CAM kinase activity is unique because what we grow up in cell culture here in our clinical laboratory is human brain cells, not the patient's brain cells, but human brain cells. And we incubate this serum that's presented to us on these brain cells. And we, through radiolabeled pulse chase P32, we identify whether or not the radioactivity label is taken up by the cell into the activity because CAM kinase actually uses it. And because it uses it, it will uptake it and we'll get an increase in radioactive isotopes that we'll see and we'll count, and we'll see how high above normal this is, because an antibody shouldn't be calling for the activation of CAM kinase. Why is that? Well, CAM kinase is responsible for the upregulation of the neurotransmitters dopamine, epinephrine, and norepinephrine. So you don't want an antibody calling for increase in the levels of these various types of neurotransmitters in the brain. So we published a couple of studies, or I would say 12 clinicians helped us publish this. They were patients who were looked at before and after treatment, and looking at whether or not these antibodies correlated with symptoms that were either improved or worsened, and how effectively and strongly these antibodies were correlated with their presentation. We did divide them into two groups, because those that improved and those that did not improve, and we found that all of them had multiple infections. This is an important thing to remember. These patients typically will have multiple infections. We also looked at the group that either improved or resolved compared to the group that didn't improve and resolve. They had very similar symptoms, percentage of concentration, OCD, emotional ability, etc. So there was no difference in that. It was really the treatment that was different. And again, remembering these patients need treatment that address the immune system, the infection, and the inflammation. And so in the patients who either improved or resolved prior to their treatment, all of them had one or more antibody positive, which is why we test for 5 of these, because it has to do with whether or not their symptoms, which symptoms they're presenting with and which antibodies they are directed against. And this is the post-treatment profile of those patients who improved or completely resolved. And what you can see is the dramatic change in the positive number of antibodies present at elevated levels. And basically that equated to a very high 90% clinical correlation between that. I won't go through and show the opposite one, but actually those antibodies increased in many of those patients who didn't improve and actually got worse. So to kind of sum this up, precision medicine is really important to be able to get effective diagnosis and treatment to patients. And by doing that, we have the ability to identify autoimmune antibodies and separate these patients into those that are immune mediated, whose treatment can be changed to immune modulators, anti-inflammatory and anti-infective agents, and patients who are not immune mediated, who will typically respond well to traditional psychiatric medications. So the goal would be to test first before we put patients on these long-term therapies, or the trial and error, in order to be able to do this for long periods of time, because they typically do not respond and often get worse with psychiatric medications. On our website, we have really dozens and dozens of patient stories who have been sent to us on their journey. This is Grace, who had a host of oppositional defiance. Interestingly, she was diagnosed with a mental disorder at age 8. She was trying to kill herself. The parents emptied out their 401k twice with no answers. The doctor found out about us, tested, found out that she had these autoantibodies, treated the immune system, and her mother sent us this picture not too long ago, completely well, back to normal life. Another young man named Adam, he was diagnosed with ADHD. They began to think, well, he must have autism because he's not responding to therapy and medications. And they were thinking of putting him in an institution. They actually happened to move to our state, and they found out about us, and the doctor tested him. He was positive, and they began treating him for the underlying inflammation and the immune system dysfunction. Not too long ago, his mother sent us this picture of him running cross country, saying recover is possible. He's 10,000 times better. So let me summarize it by saying, here's some common things we see in patients who typically are positive in the anti-neural antibody profile. and they include treatment resistance to standard neuropsychiatric drugs. Our goal is that they don't have to go through this, but typically they will go through multiple rounds of neuropsychiatric drugs with no response and sometimes even worsening. Lots of infections. But remember, infections can be subclinical. They might have been diagnosed with neurologic Lyme or post-treatment Lyme disease. And sometimes you'll see very often a family history of autoimmune disorders. Now, not all the time, but I would say that probably more than 3/4 of the time, you'll find that there is an autoimmune dysfunction in the family line. Sometimes these are sudden and rapid onset of these symptoms. Now, they can be gradual, but that is not the criteria for PANS and PANDAS. It has to be sudden. But again, remember, it doesn't mean that they don't have a similar syndrome that's a medical model that's similar. OCD, sudden onset, and even this restrictive eating disorder, motor or vocal tics or choreiform movements, and then anxiety, rage, as you saw in many of these different individuals. Sometimes depression, developmental or behavioral regression. And because the CAM kinase and because the basal ganglia affects the eye and the pupils, you can see in patients dilated pupils. Now, not always, but it's one of the things that you'll see, mydriasis, relapsing, remitting. One of our most frequent users of the panel, who is a pediatric neurologist, says that every patient, if you ask them, that exhibits and is positive for this will have acknowledged suicidal ideation. So it is important to recognize that this is the case and that need to be diagnosed and identified quickly. PANDAS, PANS obviously is important. So in summarizing the treatment, really the first thing to do is you want to identify and treat all these infections. To remember that one young girl who was actually treated with just antibiotics had a full and complete recovery because it was caught at least early enough on. Then you want to treat the inflammation because this inflammatory pathway with chronic inflammation can lead to many of these things that we talked about. And then treating any of the immune dysregulation, immune dysfunction. So as you saw many of these treatments, maybe you may not have access to these treatments, but the thing is important is that if you identify modalities that impact, let's say, infections, inflammation, or the immune system, you're on the right track. So you want to provide symptomatic relief, and we'll summarize it with the 3 I's. Treat the infections, S, treat the inflammation, treat the immune dysfunction. And remember that as you do this in chronically ill patients, sometimes you'll have these things that show up that might be a little bit more difficult to treat, but you actually, if you'll go through and continue to work with the patient, gut dysbiosis, metabolic dysfunction, Herxheimer reactions, all of these things in order for the patient to completely recover. So what's the ordering and testing process through A&M? They're our partner there in Europe. They will assist you and aid you as you place the order. They'll facilitate the transfer of the blood specimen to us into our CLIA COLA accredited clinical laboratory. Know that it takes 2 to 3 weeks for these highly specialized tests. We are the only lab in the world that runs these tests. It is a very high complex. We develop them here. And then we produce and put these results up on our secure, it's a HIPAA compliant LIS system. The reports then become available, and then you can have clinician or physician or consultation through A&M or through our 2 nurses on staff that we have here. And we're always happy to help either through webinars, through consultation, through in-services to help you. So let me end here by just giving you an analogy. I adapted this from Dr. Sidney Baker, who is a part of the Defeat Autism Now movement. If you're sitting on a tack, the treatment is not 2 Advil every 3 to 4 hours, or in the UK, I think you have a different trade name for it. But the treatment for tack sitting is tack removal. And the underlying message is search for the root, treat the cause, not the symptoms. A second tack law is if you're sitting on 2 tacks, removing 1 tack doesn't eliminate 50% of the symptoms. So in other words, if you treat the infection, but you don't treat the immune system, or if you treat the immune system and the inflammation, but you still have the infection, not going to completely resolve. And so complex conditions are complex, and to be effective, you need to address all the underlying issues for resolution. And so I'm going to pause there and turn it back over to Jillian. But we want to thank you we know you're at the front line taking care of these patients. We're here to help. We see some remarkable recoveries in patients getting well. And our goal here is to bring hope and healing to those who are suffering from these autoimmune neuropsychiatric conditions. So thank you.
Thank you so much, Professor Shimasaki. That was fantastic. And it's amazing all the sort of new insights that you're bringing in too, like the correlation with cancer, even though it's the opposite effect. Maybe at some point we'll have a panel from you for that as well. But let me go through the questions now, because we do have quite a lot in both the Q&A and the chat. So I'll go up to the top and just go down in no particular order. Alessandra, that's Dr. Piquito, mentions that the university told them there was no cure for Huntington chorea, but that's not actually true, is there? I mean, cure is always a difficult word that we're not really supposed to use, but there are definitely avenues for relief, aren't there, if one recognizes this avenue here?
It is challenging, and you're right. The word cure is very reservedly used.
Mm-hmm.
There are treatments, and there are advancing additional treatments, and really, I mean, even just heard about things for diabetes type 1 and type 2 and things that are advancing. So I'm not highly up to date on that area, but I do know that there are advances and things that are positively impacting the well-being of patients in that area.
Yes, and as she mentions, when she was teaching in Turin, she had students with dysgraphia and dyscalculia and autism. And of course, if one is aware of the fact that these can be infection-triggered autoimmune encephalopathies, one can both approach these students differently and also perhaps guide them in the right direction. And luckily, we do have the PANDAS UK charity here in the UK, who even teach courses now in schools to highlight to teachers that in children with these kinds of conditions, it could perhaps be PANDAS, to use those terms with the P at the beginning, which is fantastic. And we will have in our PANDAS discussion group, we will in the second half of this year have the PANDAS charity speaking, which is going to be great. Another question here: does a deficiency in certain minerals and vitamins also play a role in these disorders, such as vitamin D or magnesium?
Certainly, there are metabolic effects that occur when you have these chronic immune-mediated disorders, and then they do spill over into, let's say, mitochondrial dysfunction, other types of dysfunctions, and so yes, they do help. I'm not aware of anything that's directly related to just those deficiencies as being the root cause, but they certainly are a resulting additional problem that impact the ability of the patient to get well. Again, the 2-tack theory, you do need to address all of these other conditions, because sometimes once you do address the infection, the inflammation, you've got these metabolic conditions that still need to be taken care of. So vitamin D3 and of course vitamin K, and those things have been shown vitally important to be especially during COVID. And vitamin D is not really a vitamin. Vitamin D is a hormone. And so it is very important and a part, and so is magnesium and various things in our body.
Another question is whether any of these abnormalities that you've just highlighted can appear on scans, whether MRIs or CT scans.
I did show the one paper that had a very large number of patients who were averaged to look at inflammatory conditions on an MRI in the brain.
Mm-hmm.
The challenge is in imaging is there hasn't been a real good imaging tool to be able to diagnose this because you don't really have a good sense of what was normal for that patient and
Mm-hmm.
what is now normal or what's happening. So, and sometimes these inflammatory conditions are somewhat subtle. So, as you might have seen in that publication, there were a lot of patients and it was averaged, and you did see the inflammation in that. So currently today, there's not really a good imaging tool that can help with the diagnosis of these conditions,
Mm-hmm.
but they are looking for different ways of looking at imaging. And there is at least pointing to, again, the basal ganglia and inflammation in that area.
Yes, thank you. Moving over just now, I'll hop between the two to the Q&As. Another doctor here asks, can children get treated using the Autoimmune Brain Panel results in the UK? Of course, that is something that we do address in our, as I say, PANDAS discussion group. It is a little difficult simply because there is no recognition in the NICE guidelines. Those are the official sort of guidelines used by the NHS of this condition in the UK. Sadly, I believe that's the case in some states in the USA, isn't it? Even though you have, almost 30 years on us, you're 30 years ahead of us in the recognition of it over there. But it's difficult, isn't it? It's
It
something.
is.
I'll talk specifically to this doctor about who one can approach here, but it isn't easy, is it? And in the US, I believe you sometimes have issues too.
It is, and I think to remember one thing, PANS and PANDAS are a specific diagnosis. Obviously, a child, sudden onset, PANDAS for strep, etc. And many of these patients, and what we're talking about, obviously the schizophrenic patient would not have been a PANDAS patient, et cetera. What you're really looking at is this a inflammatory mediated autoimmune basal ganglia encephalitis or an autoimmune encephalitis? And that tends to be a bit more accepted in the medical community than when you deal with these acronyms that sometimes have preconceived notions. So often, though, it's important to be able to identify, and then again, testing is important because you can demonstrate that there is abnormalities in the antibodies.
Mm-hmm.
You don't want to have antibodies against parts of your brain, no matter what you call it.
Exactly.
So it's important to have biological evidence, and then it begins to help. But yes, in certain circles, it is a little more difficult. It is getting more recognized in the United States, and I think the evolution of the terms are going to continue to evolve, whereas it will just be a little bit more medically accepted.
Yes, and we do have the Children's E-Hospital, of course, here, which specializes specifically in this condition and does see children up to the age of 19. And Dr. Indra, who has spoken to us with her group, who sees at the Children's E-Hospital adults as well. So there is growing recognition. You're absolutely right, and the charity is very helpful from that point of view. As this is an autoimmune disorder, do you know of any relapses post IVIG or plasmapheresis, especially if the groundwork isn't done of removing the factors that are actually triggering any body inflammation, which can then trigger brain inflammation?
Yeah, yeah. So that's a great question, and it is kind of representative of the two-tack theory here.
Mm-hmm.
We'll see an improvement in the patient's symptoms, and you will see patients, in some cases, really, remarkably well for a period of time. But let's say they have chronic infections and they still have not been addressed, and they're still generating antibodies. Eventually, you do see, and you can see, if they're not addressed, that often there will be what looks like a relapse, whereas these antibodies are now being regenerated. So it is important to treat all infections or look for infections. But having said that, when you've done that and you do treat the immune system and the patients have had, like in this case, describe either plasmapheresis or IVIG,
Mhm.
often what we do see is that these patients do really well and they get off all of these other medications. So you do want to treat the infection, the immune system, and the inflammation. And then typically what you'll see is a longer sustainability of a patient's wellness.
Thank you. Yes, Sabrina Finn writes here that she has actually published her own book on nutritional support for anxiety and depression. And indeed, it would be very, very interesting to factor in these autoimmune aspects into that. And we can talk about that perhaps on our webpage. We could publish all the textbooks that exist. We have got lots and lots of references, all the scientific references, which are all peer reviewed, including of your Autoimmune Brain Panel on our website. But maybe we should include all the textbooks as well, because there are so many now, aren't there, that do incorporate these kinds of conditions with the autoimmune background as well, and also the nutritional components.
Absolutely.
So,
And it is so important to recognize that and I think of just nutritional components, but also just natural products. Because
absolutely. Yeah.
a vast majority of our formulary, still a good percentage arose from natural products, which aspirin and all the ASA derivatives from the bark of the willow tree, vincristine and vinblastine, which is a cancer drug from the periwinkle, digitoxin from the foxglove. You just go on and on, opioids, all the narcotics from the opium poppy.
Mm.
So natural products, nutritional components, these are all essential and part of this health healing process, and,
Mm.
as well as the frame of mind, the state of an individual, the stress level, the external toxins and things like that are all very important in getting your immune system back well.
Yes, thank you so much for mentioning the natural products too. We will also be having Dr. Jodie Dashaw speaking in the second half of this year. She has now said yes, and she's also very, very well known for her wonderful herbal approaches. Another question here is whether IVIG, and that's intravenous immunoglobulin, is available for PANDAS in the UK. It is used, so one can't say it isn't available, but it is difficult to access. And, one needs a neurologist to sign off on it. And particularly for children, that can be a challenge. And it is very, very expensive as well. So it's also not a sort of one-shot approach either, is it, Professor Shimasaki? I mean, you can't assume that just, that will be the solution, as it were, but that can be decided with the neurologists and the doctors that you have in your team.
Mhm.
Have you ever seen IVIG, just one round of IVIG helping? I remember in one of your cases, you said within 2 to 3 days, the patient was back to baseline. I think that was after azithromycin. That's an amazing recovery there.
Yeah, and it certainly depends again what the underlying root is and how long the patient has been there. Because
Mm.
if you've been infected for many months and maybe multiple infections for years, you've got a very strong immune response and a lot of plasma cells producing antibodies that
Mm.
and memory B cells. And so sometimes this is why you see rituximab and other CD420 anti-CD420 monoclonal antibodies being used for treatment to remove these B cells so the patient gets a fresh start on the immune system again. But yes, there has been, and there's been studies that have been published that have shown the effect of a single dose. There's been other studies that have shown multiple doses. There's been other studies shown, and again, for these patients, typically they're not the low dose. They're 1 to 1.5 grams per kilogram per patient, and because you're not just supplementing these with these low dose IVIG.
Yes. One more question, perhaps relating to that. With a patient who's been suffering for 20 years or more, what are the chances of an antibiotic, IVIG, or plasmapheresis helping? In other words, does the period of time make it harder to find resolution? That's what this therapist is asking, whether you have any case studies where IVIG or plasmapheresis or antibiotics were not
Yeah,
used or successful, i.e. with viral infections. That's two separate questions, really, actually.
yeah, and I think the question is really, does the duration of time of this suffering for this condition impact the ability to recover?
Yeah.
And from what we have seen, and basically probably from some of the science, is that when you address the underlying root issues of that and you address these, and then of course there's some metabolic issues and other things, and sometimes you need cognitive behavioral therapy because there's a lot of things that have gone on, but we do see just remarkable recoveries irrespective of the time. And I believe that's partially because this particular condition is related to antibodies versus T cell direct killing or anything. Whereas, let's say, like in MS, where you see autoimmunity that's a lot based on T cell destruction, using T cells to destroy cells, these just interfere and appear to just cause, let's say, just haywire in the brain. When you resolve it, what you do see is these patients can have some really dramatic recoveries. Now, it doesn't mean that you don't need to fix their metabolic system and maybe some cognitive behavioral therapy, but we do see that many patients who have been suffering for long periods of time have experienced some remarkable recoveries when you identify the root and you treat the root.
Right, thank you. I'll just ask one more here from Q&A and then go back to the chat for a couple more. Elaine asks, what's the cost of the testing, and do you also look for mold, biotoxin, and mycotoxins as part of the potential infective organisms? Regarding the costs, it is unfortunately an expensive test, but nevertheless, putting together different tests that might not be as effective as this, as actually identifying a pathological, an actual, positive on the test, can be extremely valuable. And many parents are and of course, older patients as well, are very, very pleased to finally come up with something positive that helps to answer all the suffering that they've gone through. So do contact info@aonm.org or simply give us a call. The number is on the website because the costs do vary depending on the courier requirements. It does need to be sent in a very special sort of large temperature controlled nano cool box, and that does cost to the States as well because it needs to go by Medical Express. So please do contact us to find out about the costs. They're not prohibitive really, but of course, it all counts. One other question from here relates to cryptopyrroluria, whether that could be seen as part of the symptom presentation. That is where there's a glitch in the production of heme, and that can certainly be a contributory factor. I don't know whether that's something that's tested for a lot that you hear about, Professor Shimasaki. I know that Dr. Nancy O'Hara, when she gave us presentations, she's done several for us, has always said that yes, she does see that in most of her patients, interestingly.
Yeah, that I think that she would know more than I would know, because she sees those patients. But there are a very lot of different things that you can find associated, often that go back to the root of this. So, for instance, I didn't see any questions on POTS, postural orthostatic tachycardia that can and do tend to occur, and you see these patients that exhibit that at the same time, again, an autoimmune condition. So I will defer to her on that one.
Thank you. I'll just, I know that we're running over time. Oh gosh, yes, it's very, very late. I'll just ask one more perhaps from the chat, and we will save these questions, all of them. Martin, please do copy them over, because I'm very much hoping we can speak to you again, Craig, later in the year. Patricia here, Dr. Barman, says, I've recently met the mother of a 16-year-old man who has nonverbal stims and exhibits various spectrum symptoms. The mother is certain this was a result of vaccines at 6 months. Would he be suitable for this type of testing and treatment?
Possibly, and certainly patients can have comorbidities. So it might not be unusual to have, let's say, a comorbid ASD with, on top of that, an immune-mediated neuropsychiatric condition on the top. If that was the case, then treating that part would return the patient to baseline for whatever that morbidity is. But we have seen some remarkable recovery. So I would say that, look at the patient's history, if they've suffered infections, if they have any kind of, let's say, autoimmune family history, if they are also not being improved or getting worse by treatment, so treatment resistant to maybe treating psychiatric symptoms. You've got a lot of these things that would say it could be worth and would be worth testing. Now, what I say is that as you mentioned, the test is costly, but the answer to this will give patients, as we saw, sometimes spending $20,000 to $100,000 on different types of therapy and looking for answers. Most of them have said if we would have known this ahead of time, we could have just avoided all of that. And for us, we're always looking at ways in which we can help decrease the costs, but frankly, it doesn't even cover our current expenses. But we do have many people who help support us and help the testing while we work to address that. But our goal is to help support getting people identified, getting them well, and then being able to help change how medicine is practiced for these patients.
Thank you. And anyone who's on here and isn't yet on our circulation list to get information about either our regular webinars, of which this is one, or would like to be on our PANDAS discussion group, which is a bit more private and only for doctors and therapists, please do contact us and ask to be put on those lists. Malika, for example, has asked, is there any other treatment than antibiotics? Absolutely. I mean, you've heard about the pharmaceutical treatments that are more commonly used in the States than here, to be honest, like IVIG and plasmapheresis, but there are definitely many types of natural treatment and interventions that are used, and we do have doctors here supporting patients with those too. So we will be having other webinars about those specific treatments in the course of the year too. So please do make sure that you're on our lists. And there is interestingly, another From Moleculera webinar just this week, actually on Friday. I've just put the details of that into the chat. Again, contact us if you don't have time to copy that over. That is on Friday at 6 o'clock UK time. And Professor Shimasaki, can you just give us the title of that, because I don't have that ready to hand. It'll be similar to today's, but a different slant again, won't it?
Yeah, that actually, I don't recall what the title is, but it's related to the prescribers that have prescribed or at least have not yet run more than one panel, so that they can understand better what the results mean. We'll go through some of the case studies. They may be a little different. We'll also talk through a little bit more about the underlying treatments. Again, we're not providing treatment guidance, but as you mentioned, there are natural products that, and many of the clinicians that you have had in the past, we'll talk about those. But if you remember those 3 I's, things that will address the infections, things that will address the immune system, and things that will address the inflammation, because really that's where these different modalities that are we talked about are actually directed. but that they are not the only ones. And so that's the importance, because we hope that medicine, and as we do more research, will help bring on better, more advantageous medicines for these patients that are better and easier to access.
Thank you so much. And Moleculera does have patient webinars as well. So we'll also send you out the details of those. They take place on a regular basis, so they're fascinating too. However, the next one is going to be at midnight next Tuesday, so that's perhaps not such a hospitable time for us here in the UK. But Professor Shimasaki, maybe we could consider instituting something like that in the UK just once or twice going forward, couldn't we?
Absolutely,
Thank you
absolutely.
very much. That was just so fascinating and really tremendous information. Thank you, and thank you for being here. I know it was a tremendous effort for you to come over all the way from Oklahoma just a couple of weeks ago, but we're just so thankful. And thank you, everyone, for being here this evening as well.
Thank you, Jill. Thank you, your team, Martin and Peter and Claire and everybody there who doing such a great work to help people there. So we appreciate you also.
Thank you. Just contact AUNM if you'd like any further information. The information is on our website if you haven't picked it up from the chat. So thanks again, Professor Shimasaki, and thank you, all the attendees.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Bye.